I think it's not just an issue in this particular area in beta blockers. I think it's very widespread, not just in cardiovascular medicine. There is a feeling, I think, in most people that older patients probably don't tolerate drugs as well. And of course there is an aspect to that in terms of these patients being on a lot more drugs, and there's the potential for interactions of therapy. I think it's important to again reflect that this is randomized data, and so a lot of the side effects you tend to see in observational data really aren't borne out in the randomized data, which tend to show that beta blockers and placebo have very similar risks of side effects. In fact, we saw major side effects like discontinuation because of slow heart rates or low blood pressure actually were very low. They were in the 1% range. So it suggests that these drugs can be given to most patients in clinical practice, even if we have a slight hesitation in terms of our clinical practice. I think what you take from this is that elderly women and elderly men derive a benefit from beta blockers if they're in sinus rhythm, and that these drugs should be used in those patients. And regardless of their age and their gender, older patients can tolerate good doses of beta blockers with relatively low rates of major side effects. And I think that's the key area to take away, is that we should practice by the guidelines, but also try to keep our treatments equal between men and women. And the one other thing to mention, I think, really is that women are underrepresented in all of our clinical trials. Now, that was true for our data, which were obviously based on trials over the last 10 or 15 years, but even more recent randomized trials have continued to recruit much lower rates of women than they have men. And I think that's something that all of us need to work towards, to make sure that the treatments that we have data on have good evidence, not only for men but for women, so that we don't then require these sorts of pooling projects just to have sufficient numbers of women to show a benefit. It is tricky, and we are going to have occasional patients who are on lots of different drugs for different conditions. The key thing is to look at the drugs that have shown prognostic benefit. So we've shown here that beta blockers have a clear prognostic benefit if you're in sinus rhythm with reduced ejection fraction. And there are other drugs, of course, that have similar prognostic benefit that have been shown. For example, ACE inhibitors, for example, aldosterone antagonists like spironolactone or eplerenone. And also in the other fields, so in diabetes, for example, making sure that diabetic control is good, that control of airways disease and all these other concomitant conditions. And I think it is tricky for individual clinicians and individual patients, but it really, from our point of view, it's taking away what are the benefits from prognosis that have been demonstrated in good quality randomized controlled trials. So to go from here, one question that has come up in our paper last year in The Lancet, and again in this analysis that we're presenting today at the European Society of Cardiology, is what is the impact of heart rate on all of these questions? We've long thought that perhaps heart rate may just be a marker of disease rather than something that we can target, although we have randomized trials with other drugs that have looked specifically at heart rate that have shown benefit. So the next area for us to look at really is what's happening in sinus rhythm that's different to atrial fibrillation. That means that patients in sinus rhythm benefit from beta blockers, but patients with atrial fibrillation don't appear to. And so that's the next area that we're particularly interested in, and we're looking to look at that analysis next.